me okay? So my name is Yang Ma Jair. I joined U of M MS group this summer, and I start, to see MS patients 3 days a week. I started already seeing a lot of familiar faces. I really appreciate you coming on busy Saturday. So please feel free to take a break, okay? And I'm going to show you a video clip. During that movie, feel free to walk around, okay? So today, I'm going to cover overviews of MS, what we know about MS, pathogenesis, and a subtype of a disease. It's important, as we know, different type of MS will lead to different type of management. So we're also going to talk about what are the clinical predictors for progressive form of MS. And hopefully we'll cover current management and future management of progressive MS. So as you all know, multiple sclerosis, by name, multiple means there are multiple multifocal lesions. Sclerosis is scarring. So when you're looking at MRI, everybody is familiar with MRI. You see those white spots. So that's the scarring tissues in the brain. So it is a chronic inflammatory demyelinating disease of the central nervous system. Central nervous system means your brain and spinal cord. And it's multifocal. You see multiple spots on the brain. So when you look at underneath those scarring and tissues breakdown, you see those nerve fibers. It's analogy I can give you is like your electrical wires and wrapped around insulation. So when that insulation gets disrupted, it's called demyelination. As showing on this slide here, you see disruption of myelin that wrapped around the nerve fibers. That's called demyelination. So this can occur in various places in brain and spinal cord. So underneath the myelin, that's your nerve fiber. Then over time, it starts to degenerate. That's called a nerve degeneration. So there are two ongoing processes, inflammation-mediated demyelination, and underneath nerve fiber loss we call neurodegenerative process. So it's going to become important when we talk about the progressive form of MS. I just want to point that out. So in terms of MS, what we understand is an autoimmune disease, as you're probably familiar, heard about diabetes and lupus and rheumatoid arthritis. What autoimmune disease means, there is an overactive immune system target specific organ. In terms of diabetes, it's your pancreas, lupus, maybe kidney and your joint, and rheumatoid arthritis, your joint. In the case of multiple sclerosis, it's your central nervous system, your brain and spinal cord, and specifically those myelin got targeted. But it started outside your central nervous system. So immune system is thought to be the initiator for this autoimmune disease. So I'm going to show you a video clip and explain all the players in this disease. So you can doze off and take a nap, or you can look at it just so we can have a break. So let's see how we're going to play this. Okay. Where is the mouse cursor? Did you see the cursor, guys? Okay, here it goes. So,
when the immune system malfunctions in MS, the result is an attack on the body's own myelin, including its myelin-producing cells, the oligodendrocytes. This attack is thought to be due to a complex interaction among several components of the immune system, including macrophages, cytotoxic T cells, B cells, and various cytokines, such as gamma interferon and interleukins. The immune response is initiated outside of the central nervous system when a self-antigen, such as a myelin-type protein, possibly a virus, is phagocytized by a macrophage and subsequently presented to an inducer T cell. The inducer T cell then becomes activated and releases a number of cytokines into the blood, including interferons and interleukins. These cytokines act on other immune system cells, such as B cells and other T cells, to further augment the immune response. Cytokines, such as gamma interferon, cause the endothelial cells lining the blood vessels to express surface adhesion molecules. Once activated, T cells bind to these adhesion molecules and essentially walk through the blood-brain barrier into the CNS.
Okay, so that's the end of it. You see those bad T cells going through blood-brain barrier, attack your central nervous system, tissues, and myelins. Okay, so this is a brief overview of MS. As we know, so far we haven't found the exact cause of MS, but we know it's an immune-mediated inflammatory disease of the central nervous system. As I explained, we don't know who's going to get MS, but there's a genetic underlying susceptibility in people who were exposed to early pathogens, infectious agents. There's some molecular mimicry theories, and how myelin get attacked. It's a similar agent that was presented on peripheral immune cells. Okay, so it's a very complicated disease process, but we know there are a lot of cells involved. Leukocyte means your peripheral white blood cells. And there's T cells and B cells. They're all white blood cells, and they're macrophages. They are together kind of like a symphony orchestra. They orchestra an autoimmune attack on the myelin. Okay, so to simplify it, that's the overview that what we understand about MS. But now I'm going to switch gears to talking about different type of MS. It becomes important when we talk about management. It's a different type of disease will have a different treatment. So the most common type of MS is called the relapsing remitting MS, where you see the graph here, a peak and then valley. The peak represent different set of symptoms. It can come on, and I'll give you examples and talk about it. It can last weeks to months, followed by a quiescent, disease-free period called remitting. So 85% of MS patients present with a relapsing, remitting type of MS. But over time, around 10 years down the road, 50% of a relapsing remitting patient will become what we call secondary progressive. So secondary progressive, when you start to see patients have less of a relapse, less of a sudden symptoms or flare up or exacerbation, but more of a slow progression. That's what we call secondary progressive. So there are other type of MS. Well, let me give you an example of this. So this is a case that of a 44-year-old lawyer I saw in my clinic. So he initially developed right eye loss of vision at age 31, and then got treated and symptom resolved. So quickly, just review, and at age 33, he had another episode of numbness and weakness, lasted about a couple of weeks, and then completely recovered. So he was not treated with what we so-called disease-modifying agent. So, and he remained symptom-free for 5 years. Then he had another attack, another relapse, with double vision and leg weakness, bladder and sexual difficulties. So this sounds familiar to you. You can see there's flare up of set of symptoms, and then he could be fully functional and symptom-free, going to remission phase for a couple of years and start to have a different attack. So this is a classical case of relapsing remitting MS. But 6 years later, he complained about a gradual increased leg weakness. He had to stop and rest after walking a football field, more than that. And he also has short-term memory loss and fatigue depression. He feels like he loses train of thoughts when he argues cases in a court. So do you notice there's a change of presentation? It's a gradual change of weakness I noticed. There's no flare-up in between. So at this point, he has gone into progressive phase, we call secondary progressive. So different from secondary progressive MS, there's a type of MS we call primary progressive multiple sclerosis, where you see steady decline of function over time with no acute exacerbation or attack or flare-ups. Okay, so you see this line. What did I do? So slowly going progression without sudden flare-ups. Let me give you an example of primary progressive MS. So a 50-year-old building contractor began to notice a very subtle weakness when he starts to ski in the winter. And gradually he noticed tingling on both feet and hands. And then he also had urinary issues and balance problems and more trouble walking. But there's no sudden change of his status. So that's what we call primary progressive. I want to show you this diagram. Basically, there are 4 types of MS we know, and the most common kind is called a relapsing remitting MS. As showing the yellow line here, you see peaks and valleys. Like I talk about, the peaks represent relapse and valleys are remitting phase and quiescent phase. But you can tell people are different from each other. Any given patient can present any form of MS, and we can't predict which one going to have progression versus relapsing form. But early on, 85% of people present with relapsing remitting. And over time, you see progression that's called secondary progression. Primary progressive MS, it's where you see progression from get-go and gradually going deterioration. And there's another rare form of MS called a progressive relapsing, which is less than 5% of our patient population, where you see progression. On top of that, there's superimposed relapse. So that's the orange line. I put it down below. And if we break down the prevalence of those 4 types of MS, as you can see in this pie chart, 50% or more than 50% of patients are in relapsing remitting phase of the disease, but 45% are in progressive form of disease. Breakdown, the most rare form is progressive relapsing versus 10%, about 10% of primary progressive. So rest 31% are secondary progressive MS. So how do we measure progression clinically? As we know, when disease progresses, people tend to have less of flare-up and relapse. So measuring relapse rate is less useful in progressive cases. So what we use is something called EDSS, as Dr. Willie mentioned. It's called Expanded Disability Status Scale. As I show you here, it's 0 to 10. Of a scale, 0 means normal and 10 is death. And mild to moderate disability fall into 2 to 3 of a score. And requiring a cane to walk, it's around 6. And 7, it's require a wheelchair. And bed bound and chair, it's around moderate severe disability 8 to 9. So you can see this is how all the clinical trial was done to use EDSS to measure progression. So if we break down how progressive MS is different from relapsing remitting MS, and you can see 0 to 10 of a scale, there's a 0.5 point of increment. So the yellow bars are progressive form of MS. They tend to cluster on the right-hand side with more of a severe disability, and the relapsing remitting kind of MS has less of a disability. If I break down 2 different types of MS, as you can see, RRMS has average of EDSS 2.5 to 2.7, and secondary progressive, primary progressive relapsing MS patient has higher EDSS score, around 5 point to 6 point. So what are the clinical differences, just to be brief, and I want to cover briefly. Usually relapsing remitting MS patient has early age of onset and tends to be female predominant. And later on in secondary progressive and primary progressive patient, you see the ages is older and it's a more male predominant. But secondary progressive tends to have more cognitive impairment versus primary progressive MS patient tends to have more leg weakness. But they actually overlap. To diagnose the two sometimes is very challenging. And I wanted to point out what we have currently to predict who's going to go into progression. And mostly we rely on clinical presentations, especially early relapse. Okay, and early frequent relapse tends to predict worsen outcome. And also high lesion load means more white spots on MRI at the first clinical event tends to predict worse outcome down the road. And of course, early presentation with more disability of EDSS above 3.5 also predict poor outcome. So recent activity including increased relapse rate, frequent relapse, and more multifocal of disease, and incomplete recovery from each relapse. Those are all predictors for progression. And unfortunately, male at a later onset is a poor predictor for progression. And poor response to corticosteroid treatment as well as disease-modifying drug, I'll talk about it a little bit later, is also a predictor for progressive disease. So when we, as Dr. Braley already alluded to, over the past 20 years, there's 6 drugs being created for treatment of relapsing remitting multiple sclerosis. We call them disease-modifying treatment. All of them are targeting an immune system, so they modulate your immune system to decrease the relapse rate. So they're very effective in terms of control relapses, but none of them have shown to be working for progressive form of MS. Okay, so I want to say, so what are the options for secondary progressive MS? One of the drugs has been approved in US is called mitoxantrone, Naventron. It is the only drug that is approved in US for treating secondary progressive MS. And listed below, there are several off-label treatment that we commonly use for secondary progressive MS. They're based on smaller studies, and the evidence is not as robust as from larger studies, as you can tell. So I listed interferon there because interferon, Avonex, Rebif, and beta-seron, especially they're all being tested in progressive MS. An example I can give you is the interferon beta-1b, beta-seron. When they did North American studies versus European studies, so they have found conflicting data. So only when people still has inflammatory or current acute relapse seems to be responding to interferon beta-1b. So the conclusions is if you're still using interferon at the transitional stage from relapsing remitting to secondary progressive, then there is a possibility of response. But when people really go into progressive phase, they're less likely to be effective. So I'm going to go through some of the treatment that we could use for secondary progressive MS. So mitoxantrone, Naventron is a broad immunosuppressive treatment which had been used by oncologists for treating prostate cancer and it's leukemia as well. So it is used by us at very low dose. It's not as high dose as oncologists use. So it can be effectively decrease progression, and especially for people who has acute rapid worsening of relapsing remitting disease or secondary progressive MS. we could use Naventron to halt the progression. Okay, but it doesn't come free from side effects. So commonly we have to discuss with patient. There could be nausea, vomiting, hair thinning, and the most worrisome side effect is the cardiotoxicity, means the drug could affect your cardiac function. So you have a decrease of cardiac output. That has to be monitored, and there's a ceiling dose of how much you can get. Usually it's once every 3 months we do infusion, and a maximum treatment is over a 3-year period. So it's not the long-term forever treatment option. But we do use that for people who has rapid deterioration, and occasionally we use for rare form of MS. It's in progressive relapsing form of MS. We also could use Naventron. And another drug I want to mention briefly is the oral pill that we can add on other treatment. It's called the methotrexate. It's also a broad anti-inflammatory drug. It has been used by rheumatologists for rheumatoid arthritis. So it's easy to take because you can take it once a week as a pill dose, and it's usually well tolerated. But there's potential side effects of liver toxicity and long side effects. So it could be used, but the data is, evidence is coming from smaller studies, and so it's a weaker of choice, I need to mention. So another possibilities for rapid progressive MS we can consider is called Cytoxan or cyclophosphamide. It's a broad immunosuppressive treatment given by intravenous infusion once a month or once every 2 months. But it can cause a couple of potential side effects. One is lower your blood count, and the other, it could hurt your bladder and cause bladder bleeding issues, and potentially can increase risk for other malignancies, theoretically. And also can cause nausea, vomiting, hair thinning, infertility. So it has limited utility because of the side effects, but it is effective when people failed other treatment or have rapid progression. So it's a decision between you and your physician to weigh the risk and benefits. So current management strategy for progressive MS is to treat folks early, especially when they're at relapsing remitting stage, because we have 6 effective drugs out there to treat patients to prevent relapse. And data have shown that to treat patient early will be helpful in the long run to prevent disease progression. So when people transition from relapsing remitting to secondary progressive MS, you can still continue using those disease-modifying treatment if they still have inflammatory activity on MRI. And mitoxantrone and the chemotherapeutic drug, as I mentioned a few, they all come with side effects. They're more potent, and they tend to be more effective for progressive MS, so it can be used for progression. Okay, so as I summarize, it is very, very challenging for MS neurologists, as you all know, to treat people with progressive MS. And as I mentioned before, disease-modifying treatment could slow down progression if you start early on, but they lose their efficacy over time if there's no inflammation on the MRI or disease become more progressing. So if that happens, we tend to tell patients to stop what they're on as ABCR drug and to step up to use more potent immunosuppressant or chemotherapeutic drugs such as Tysabri or Naventron or Cytoxan. So there's minimal benefits showing using low dose of methotrexate, but you've seen physicians using that as well as the adjunct treatment for a progressive patient. So what we tend to do in clinic is to focus on symptom management. As you all know, you could develop pain and spasm, and you could have bladder issues, and mood and sleep difficulties. So for each of those symptoms, we have a medication to help you. So there's a newly approved drug called famotidine and Ampero, which help patients with walking speed and endurance. It helps the nerve conduct electric pulse faster. It's called famotidine and Ampero. It's easily tolerated, so it may be a drug that can help you practically. And for fatigue, we use modafinil and Provigil, if you heard about other treatment choices for fatigue. And muscle relaxant can be helpful for muscle spasms, and there are a lot of other symptomatic treatment that I'm not going to go in depth. But if you have any bothersome symptoms, so do feel free to talk to your physician, because we can help in a lot of aspects. And one thing I want to emphasize, you can't overemphasize the PTOT rehabilitation. It's really helped the nerve to regenerate. That has been the main treatment option for a lot of our progressive folks. So you don't you don't use it, you lose it. So usually we tell patient to go try to work on what is remaining to help build new circuitries. So as I talked about the disease of MS, I wanted to emphasize, as I showed you the early slides, there's a process called inflammation and demyelination. So the demyelination process is inflammation driven. There's underneath the nerve, like the cord of the wire, it's get degenerate, the nerve fiber loss. That process is called a neurodegeneration. So this two processes are going side by side. And it's only recently people start to realize actually nerve degeneration occur early on in the disease. That's going to be the target for our next decade of research. So I wanted to point out the future treatment of MS is going to be targeted more towards degeneration. We already have 6 potent drugs to treat inflammation. So we're doing pretty well in terms of managing relapse and immune modulator treatment, but not so much on neuroprotection and repair and for progressive MS. So being at University of Michigan, this is a top-notch, world-class, innovative MS center. We're currently pursuing potential target and treatment for progressive MS. So that's one of my passions. That's why I joined the U of M team. And as this is what the diagram I want to show you, it represents the current and future paradigm for treating progressive MS. So line A shows you a natural history of MS. People have over time progression on top of relapse. Okay, so if you see a general neurologist, B, you start disease-modifying treatment after third relapse. So you actually lose time. Versus starting disease-modifying treatment earlier, C line, you actually can prevent progression by starting treatment early. Okay, so that's where our current paradigm is. We want to start treating as early as possible, and so you can cut down those inflammation, okay, and to prevent future progression. But what D line represents the future treatment, what we call neuroprotective therapy. So our hope is not only we can decrease the progression of disability, we can actually halt the disease and reverse the progression. So I wanted to talk to you about our current research on progressive MS. So what we're interested in, as I showed you, there's no no laboratory markers to tell folks who's going to progression. I showed you a couple of clinical outcome predictors. So what we're hoping to do is to find serological or immunological markers in your blood. Hopefully we could tell who is likely to develop a progressive MS down the road. And other tools that we can use is something called OCT. If you heard about it, it's optical coherency tomography. It's a ultrasound technique to look for your nerve fiber layer thickness. It can be measured to reflect neurodegeneration. So there's also other MRI novel imaging techniques that we could use. So there are a lot of ongoing research we're currently pursuing to help diagnose and manage of relapsing and progressive MS patients. I wanted to point out there are ongoing clinical trials on several potential agents for treating progressive MS patients. And as Dr. Braley already alluded, Tysabri, Campass, and Gilenya, BG12, lacritamide, all of them are being tested. Some of them will be submitted for FDA for approval of relapsing remitting MS. But all of them have been are being pursued for progressive patients as well. So over time, I predict in the next decade or so, we'll have a treatment for progressive MS. And the last one I want to point out, masitinib, it's a kinase inhibitor, which is a phase 3 clinical trial, like Dr. Brady pointed out. We're involved where one of the multi-center, one of the side for doing the study. Currently, it's on hold because patients' white blood cell means peripheral cell count is decreased, so we need to monitor that a little closer. Once it starts enrolling, we'll let folks know. So this is the compound that could potentially help for progressive form of MS. That's the kind of MS that currently we have trouble and finding treatment. So in the future strategies for progressive MS, I wanted to just spend a few minutes. We're hoping to promote the growth of the nerve fibers and also to promote remyelination. There's a molecule called antilingo. It's in preclinical animal phase studies, and it has shown promises. Maybe we could use that to help grow the neurons and remyelinate. Okay, and so is the neurotrophic factor, BDNF, a brain-derived nerve growth factor, and NT3. If you have questions, I can discuss about this later. I think I'm probably running over time a little bit. Quick summary. Okay, we know progressive MS is just like MS. It's very complex. There are many new features and pathways that are being explored. And so our key focus of current management of progressive MS is to start disease-modifying treatment early so we could prevent progression down the road. But we know current disease-modifying treatment are not so effective in progressive phase of disease. So we need continuing pursue and research and studies to look for future treatment that could suppress inflammation and to promote remyelination and neural repair. Thank you.